Now, moving forward to the next session, I would like to request our experts to kindly come on stage to chair over the next session. Dr. Litan Naha Biswas, Professor and Senior Consultant in Radiation Oncology, Apollo Multispeciality Hospitals, Kolkata. Dr. Suparna Ghosh Ray, Professor and Head of the Department, Radiation Oncology, Badwan Medical College, and Dr. Santanu Acharya, Professor in Radiation Oncology, Arjikar Medical College, Kolkata.
Sudeep Gupta, medical oncologist and professor of TMH. He is not present physically. He will give his presentation through the webinar.
Good afternoon. I would like to thank the program committee for its invitation to participate in this excellent conference. The Many Faces of Triple Negative Breast Cancer, a wonderful and evocative title of my talk. Those are my disclosures. Several years ago, we conducted an audit of consecutive cases in our institution in one calendar year and found that in contrast to Western population, TNBCs constituted almost 1/3 of our patient population. The phenotypic heterogeneity of TNBC has long been appreciated by pathologists, and you can see the common, the not so common, and the rare varieties of breast cancer depicted on this slide. But more recently, using gene expression profiles as well as mutations, we have begun to understand the molecular heterogeneity of TNBC. This has been stated several times in the past, but let me say it again. The basal-like and triple-negative breast cancers share substantial overlap, but not complete. There are several other classifications of triple-negative breast cancer. The widely quoted Lehman classification or the Vanderbilt classification, the Metabrick classification into integrative clusters, and in the latter, most of the triple negative breast cancers fall in integrative clusters 4 and 10. Lehman and colleagues revised their classification in 2016. From the 6 subtypes, they revised it to 4, and it is instructive to learn as to why they did so. Transcripts in the previously described immunomodulatory and mesenchymal stem-like subtypes were contributed from infiltrating lymphocytes and tumor-associated stromal cells, respectively. And therefore, these 2 subtypes were deleted from the subsequent classification. And a very important lesson that tumor microenvironment contributes to molecular profiles and must be considered when we undertake molecular classifications. In terms of DNA, TNBCs carry on an average about 1.68 somatic mutations per megabase of coding regions, about 60 somatic mutations in each tumor, but this is not uniform across tumors, ranging from high to low mutational burden in various tumors. There are frequent copy number aberrations involving genes that may lead to multiple pathway alterations. There are several studies, but this is the one that I like the best because I think among all, it is most apt to depict the many faces of TNBC. 104 TNBC cases subjected to deep sequencing. There was a wide and continuous spectrum of genomic evolution, hundreds of mutations per tumor to very low mutations in other patients, marked variation in copy number analysis between cases, only 1/3 of mutations expressed using RNA-seq, and very importantly, TNBCs varying widely in their clonal makeup at the time of diagnosis. The case on your left has 3 dominant clones. The case on your right has 5 dominant clones at the time of diagnosis. So TNBCs well and truly come in many hues and many varieties. The ecosystem of this tumor can be thought of as the cancer cell. DNA repair defects closely related to mutational burden, microsatellite instability, several known pathways such as the PIK3 pathway, proteins that have begun to be useful targets for treatment, and several uncommon and rare mutations that can occasionally be therapeutically useful. The environment, comprising of stromal cells such as the fibroblasts and the cancer-associated fibroblasts, but very importantly, various kinds of immune cells that infiltrate or do not infiltrate a particular tumor. So we can therapeutically exploit the TNBC ecosystem, starting from cell surface to intracellular signaling pathways, intranuclear pathways, and the DNA damage response system itself. How about exploiting the immune environment? Which cells has been an important consideration, but now also where they are located, and single cell, high resolution single cell techniques with spatial resolution capabilities have begun to provide important insights into this theme. So various immune cells, the regulatory T cells, the helper T cells, macrophages, others, how abundant they are and how they are distributed into the tumor has begun to provide a description of tumors from being hot or fully inflamed to immune deserts that hardly have any immune infiltration. A very important consideration is the fact that TNBCs are not immunologically frozen during their life history. The primary tumor is immunologically warm or hot with higher antigen presentation capabilities, reduced clonal diversity, higher immune cell infiltrate, and many of these findings reverse in metastatic tumors, especially multiply treated metastatic tumors, and also importantly, reduce expression of genes that encode for antigen presenting machinery that are listed here, such as the MHC class 1. So there can be immune exhaustion and depletion. There can be infiltration by immunosuppressive macrophages and exhausted T cells. Genes can be expressed that are involved in various immune escape mechanisms, such as the ones that are listed here. And to compound matters, metastatic sites such as the liver are most immunodepleted and immunotolerant, making them particularly difficult sites for immune targeting. The PDL1 scoring system itself, from the clinical and therapeutic point of view, has been a point of contention for quite a while now. Different antibody clones, whether to score the immune cells or the tumor cells or both. And there is some perhaps substantial overlap between various scoring criteria, but not a complete overlap. And therefore, each treatment has its own companion biomarker. So monotherapy with immune checkpoint inhibitors has shown modest responses in patients with metastatic TNBC, but it has been very instructive from the point of view of biomarkers and has shown that with all their caveats and all their weaknesses, criteria such as the PDL1 scoring does have some predictive capability as we move forward. So how to create rational combinations with immunotherapy? I think the partner should increase antigenicity and reduce immune escape, perhaps reverse a mechanism of resistance, and of course, must be tolerable when given along with the immune checkpoint inhibitor. And several classes of drugs, chemotherapy, PARP inhibitors, ADCs, etc., fulfill at least some of these criteria. So combination of immune checkpoint inhibitors with chemotherapy, I will not go into the details of these studies because they have been shown many times over. This is the Impassion 130, atezolizumab compared with placebo in combination with nab-paclitaxel. Significant improvement in progression-free survival in the ITT and PDL1 positive patient population, but no improvement in overall survival in the intent to treat population. There was some evidence that perhaps the PDL1 positive population did benefit by the addition of atezolizumab, but by the rules of hierarchical testing, this was not a formal statistical comparison. The confirmatory study, Impassion 131, no benefit in either PFS or OS, either for PDL1 positive or the intent to treat population. I think in all conferences, it is de rigueur to to try to reconcile these contradictory results. So therefore, I will not recount all of them here, except to say that my own take is that we don't really know. And also, I would like to provide my 2 pence bit about the possibility of chance. The results of Impassion 130, I would like to submit to you, never formally proved that overall survival was significantly higher with atezolizumab in the PD-L1 positive population. The comparison that is often depicted, which I just did a couple of slides ago, should not have been done by the rules of hierarchical testing. These rules exist to reduce the probability of making a false positive conclusion, and therefore, in my opinion, at least with respect to OS, there is no formal discrepancy between 130 and 131. Pembrolizumab, Keynote 355, very similar design. No significant improvement in the patient population with a CPS score of more than or equal to 1, but a significant overall survival benefit in those with CPS more than or equal to 10. And the subgroup analysis confirms that the benefit is confined to patients whose tumors have a CPS of more than or equal to 10 as measured by the DACO antibody. So those are the various features of the Impassion 130 and Keynote 355. My own take is that this is likely to be a difference between pembrolizumab and atezolizumab rather than the other points that are listed on this slide. So there is a definite signal of activity of immune checkpoint inhibitors in combination with chemotherapy, at least in a subgroup of patients. But the predictive biomarkers are far from ideal, and some would lament wither precision immunology. We are using PD-L1, but there are several other things that we know about prediction. Perhaps all of these, or at least some of these, need to be combined in an integrated score that will perform better than PD-L1 testing, which we use at the current time. Furthermore, new combinations are likely to modify the current treatment recommendations in the very near future. Exploiting DNA repair defects, we already know about platinum from many studies that have been done in the past. More recently, we have the PARP inhibitors. Two important studies, again, are well known to all of you, the Olympiad trial with olaparib. Importantly, no platinum in the control arm, despite 70% of patients being platinum naive. Benefit in progression-free survival, but no overall survival benefit, and better quality of life with the PARP inhibitor. Embraca study with talazoparib, again, no platinum in the control arm, despite 80% of patients being platinum naive. Benefit in PFS, but not in OS, and better quality of life with the PARP inhibitor. In India, these results seem to have increasing importance. This is a study from my colleagues in AIIMS in Delhi. Consecutive patients of breast cancer, 236 of them, 18.5% had pathogenic or likely pathogenic germline mutations in a variety of genes. 2/3 of these were in BRCA1 and BRCA2, but very importantly, 1/3 of these were in a sprinkling of other genes that are shown to your left bottom on this slide. So what about the use of olaparib in patients with mutations in other HRD genes? In terms of germline mutations, PALB2, patients with PALB2 mutations do seem to derive some benefit from the use of PARP inhibition. In terms of somatic testing, BRCA1 and BRCA2 seem to indicate some benefit of these drugs, but other mutations such as ATM and CHEK2 perhaps not predictive of benefit. Several other HRD scores, but none of them clinically useful and ready for prime time at the current time. So from the efficacy point of view, I would say that the results of PARP inhibition in metastatic TNBC are underwhelming, especially considering the fact that platinum was not even allowed in the control arm. PARP inhibitors are expensive and not completely devoid of toxicity. Their proper sequencing with platinum is unclear. I would say that they are a reasonable option when easily available, but I wouldn't fret if they are not easily accessible. Targeted delivery of a toxic payload, antibody drug conjugates, several physicochemical properties of these conjugates that have been described for a variety of conjugates, and I will not recount them here, but they are important in their therapeutic ability. So this is the phase 3 study of sacituzumab govitecan. Patients with more than or equal to 2 prior chemotherapies for advanced stage TNBC, and those of us who treat this disease know that this is a heavily pretreated population with very poor prognosis, randomized to sacituzumab govitecan or treatment of physician's choice, which could be one of these 4 chemotherapy drugs listed here. Both for progression-free and for overall survival, there was a statistically significant and clinically meaningful improvement with the use of sacituzumab govitecan. The survival of 12.1 months with this drug, I would like to request your attention to this number. Not too long ago, this used to be the average survival of patients with first-line metastatic TNBC. So well and truly, substantial activity of this drug in this disease in this setting, manageable toxicity. There are several other antibody drug conjugates targeting a variety of cell surface antigens that are listed here in this table. But how to improve the outcomes that we have achieved with, for example, with sacituzumab govitecan, and the outcomes do need improvement. Many patients respond, but not nearly deep enough with this drug. So perhaps combinations with what we know, for example, with sacituzumab govitecan, that SN38, which is the payload, is a DNA targeting agent, a topoisomerase inhibitor, and it would make sense to combine this with another agent that damages the DNA, such as the PARP inhibitor, and such studies are ongoing. Other targets, the androgen receptor axis, occasionally useful, but in my opinion has not really lived up to its original promise. However, one important fact is the presence of PIK3CA and AKT mutations in this subtype of triple negative breast cancer. So perhaps the combination with inhibitors of this axis might be useful, and some studies are ongoing to exploit this. AKT inhibition, promising. One phase 3 study with ipatasertib negative, the other phase 3 study with capivasertib awaited. This is our own study where we looked at few patients whose tumors were longitudinally sampled over time. All of them had triple negative breast cancer, and two out of those 3 had a germline BRCA1 mutation. The tumors and bloods at each of the time points were subjected to deep sequencing for whole exome, whole transcriptome, as well as SNP arrays. What we found is that truncal mutations that are present in the original tumor persist throughout the life history of a tumor, but gives off daughter clones at various time points, perhaps correlated with Darwinian pressures exerted by chemotherapy that is given at each time point. Somatic copy number alterations increased in these tumors over time, and also very importantly, circulating tumor DNA completely captured the clonal architecture of evolving cancer in these 3 patients. So the study is about to be published. We conclude that metastatic TNBC rapidly evolves over time in any given patient, and also tumors in different patients are substantially different from each other. So there is inter-patient heterogeneity, there is intra-patient heterogeneity, and these considerations will present exceptional challenges to all treatments that we devise for TNBC. These are several drug classes that, including local treatments that we can use. You can see the interconnections, the combinations that are being investigated at the current time. Several arrows converge understandably on the immune checkpoint inhibition. But what is most required are predictive biomarkers that have a high positive predictive value and a very high negative predictive value. And I think that single cell techniques, including those involving spatial resolution, repeated liquid sampling, as well as artificial intelligence, will improve the biomarkers that we have at the current time. My final thoughts: Dobzhansky said almost 50 years ago that nothing in biology makes sense except in the light of evolution. Over a period of time, I have come to appreciate the force of this statement. Where were we in the past? And will this understanding help us gaze into the future? This is a cartoon that I drew not too long ago for another meeting. On the y-axis is progress, however defined. On the x-axis is time. Progress can be linear over time, exponential, begin to plateau. Which trajectory are we following at the current time? But also, very importantly, where are we at present on the arrow of time? And only with some understanding of these 2 points will we be able to gaze meaningfully into the future. And I think this is very true of metastatic triple negative breast cancer and triple negative breast cancer in general. I end by mourning the loss of a genius who brought joy to millions of his fans, including myself. Thank you very much for your attention.
So you can ask questions.
So, what are your thoughts on the use of PARP inhibitors in both metastatic and early stage breast cancer in the triple negative setting?
I think I said it in my talk that they are useful, but not extremely so. And if I cannot use them, I don't think patients are being harmed to a very great extent, at least in the metastatic setting. For early breast cancer, I think in patients with germline BRCA mutation, there is a reasonable benefit, and if they were to become more accessible to our patients, I would use them.
So, in the metastatic setting, in the triple negative setting, do you think that the trials, and I completely agree with you, I think Olympia D and the Embraca trial, I think the reason why there was only a modest benefit and no overall survival benefit was because of the timing for the use of the drug. Do you think if it was used much earlier, we would have seen a bigger benefit?
That's a speculation, and I think somebody should perform the study that you're proposing. Maybe you could do it. And once we have proof of the results, then we can have a discussion.
So there was a subset in the Olympia D trial that there was an overall survival benefit if they had used it pre-chemotherapy. What are your thoughts on that?
I have said it many times earlier, and let me say it again, that whenever you chop up the data in one or more ways, you introduce a very high probability of making a false positive conclusion. And which is why it is taught to all students in their initial learning that one must not chop up the data in many different ways and then fish out some results. So it is interesting. I have noted that I know about that data, but I don't think it will have an impact on my practice.
Good evening, sir. This is Joydeep here. Sir, do you suggest that we use Pembro plus chemo in the subsequent lines if the patient is a CPS high?
By subsequent lines,
you mean somebody? Yes, sir. Somebody who is like in the third line or the fourth line situation, and we have a CPS score high. Can we add Pembro with chemo in that setting?
I mean, we could do it, but immunologically speaking, there is increasing immune suppression, and as you go along, there is immune exhaustion. So I'm not very certain that if a patient has already seen several lines of treatment earlier, how much they will benefit from immune checkpoint inhibition.
Okay, thank you, sir.
That's my own take on that topic, and there are some translational studies to suggest that there is increasing immune exhaustion, which I also referred in my talk.
Hello, sir. Reema here.
Hi.
Hi. I just wanted to know when will we start, making the molecular subtypes of TNBC more actionable? Like we don't really do the molecular classification yet. I don't see any companies trying to make drugs for a specific subtype. Do you think that it is far down the future? Do you think it is a waste of exercise? Why is it that we are not exploiting that as of now?
That's a very good question. It's not that it is useless. There is a biological understanding that we develop when we do the layman classification or the metaphoric classification, for example. It is just that I showed you in our own study, there is exceptional inter-patient heterogeneity. And even patients, for example, within the immune subgroup of the Vanderbilt classification, no one patient is similar to the next one. So unlike other cancers such as HER2 positive or even ER positive breast cancer, ENBC presents challenges that is at least an order of magnitude higher. So it's not that people are not interested, it is just that the biological understanding is not being translated into actionable outcomes.
So you think a better classification using more complex pathways are in order, or how is it that we see this in future being implemented in clinics?
See, just now, if I look at our own study, I find that 3 patients will have 3 different tumors. And if you look at the study by Surab Shah and colleagues that was published in Nature, they had about 104 patients who will fall into 60 categories. So the problem is that it is not that people are not trying, and even more complex classifications may not necessarily become actionable. It is just that we have not really hit upon what shall I say, the Achilles heel of this tumor. So that's still an ongoing quest.
Thank you, sir.
How many percentage of de novo TNBC metastatic cancers do you see in your clinic, sir?
They are not very common, and I try to recruit them into some ongoing studies. I find it hard to get such patients. I cannot give you an accurate answer, but my guess is that they might be about 15% of our cases.
And here there is an immense role of sacituzumab, and I think you should give a take-home message to the postgraduates over here, because as we know about this drug, this is certainly a magic drug in this subset of patients. So what is your take-home message for the young postgraduates?
So I am not certain that it's a magical drug. It is useful, and it has produced very nice results in hard to treat patients. I'm not really sure whether it is magical yet. I don't think we can call it magical until the time that, like trastuzumab, it begins to cure more patients with triple negative breast cancer. And there I agree with Shahina that the use of olaparib in the early breast cancer, in the non-metastatic triple negative breast cancer, is a useful outcome because perhaps more patients are being cured of that.
Thank you, Dr. Sudeep, for its excellent interaction. And now I request Dr. Rosina, please come over and give your presentation.
Very much for inviting me to talk about this rather interesting topic, which I think goes beyond just what we do as surgeons and crosses over into what a variety of different medical oncologists are doing, right? Okay. So back in the early 90s, first the BRCA1 and then the BRCA2 genes were described, and this created a shockwave because these were the first genes that were ever found to be causative of breast cancer, of any cancer, in fact, not just breast cancer. And so it went from scientific literature to the lay press. And this is the article that came out in the New York Times when there was this first cautious announcement that there was a gene that might cause hereditary breast cancer. The woman who did the research, Mary Claire King, talked around the world about this, and this photograph on the right is when she talked here in Kolkata a few years ago. And then, 20 years later, there was another announcement, and this time, instead of going from scientific literature into the lay press, the announcement was in the New York Times. And of course, the Angelina Jolie effect is something that has changed the perspectives on gene testing and on the way women see gene mutations. Look at what happened. This is where surgery started to change because of genetic testing. Before her very public announcement, down here we see the number of patients who had unilateral or bilateral mastectomy, and suddenly, as soon as she had announced this, the number of patients having bilateral mastectomies went up, and it has continued to do so. So what are these BRCA genes? Well, they are tumor suppressor genes, and they're associated with the incidence of breast or ovarian cancer. But it's important to realize that they are not associated with the outcome of disease treatment. Apart from these two well-known genes, there are a whole lot of other genes which are spread across the whole genome, and it's important to remember these as well, not just concentrate on the BRCA genes. The recommendations for which patients should have testing is evolving with time. It's just getting to be a longer and longer list. But basically, testing falls into 3 different groups. You can test a person because of their personal history of breast cancer, such as young patients, triple-negative patients, male patients. You can test them because of their family, so cancers of the same or different kinds in other members of their family, or if family members are known to carry a mutation. And increasingly, there is some change towards testing for the purposes of changing treatment. As you will notice, surgical planning has not come into these guidelines yet, but they are still in evolution. In fact, if you look at family history and at cancer biology, actually just looking at family history, using the sort of tools that are available to us shown on the right, a large number of people who carry mutations may actually be missed. And so it's important to look at the type of cancers that patients have before deciding whether they need to be tested or not. Now, to understand all this, there is data, a little bit of data from Indian patients. This was the first study of about 1,000 patients, but for young patients, almost 40% of them had some kind of a mutation. You heard Dr. Sudeep Gupta just talking about the number of variations of unknown. It's also true when study, and it's also true when we look at the data from our hospital. 51% of our patients had a mutation, but 1/3 of those mutations were of unknown significance. 50% had no family history. The majority of BRCA mutations were of BRCA1, and there were a variety of other genes involved as well. Now, to understand the way through this, I want to show you a few examples. The first patient I'm putting up is a 42-year-old woman with breast cancer who had a 2-centimeter primary, multiple axillary lymph nodes. There's her family history. Her mother had a breast cancer earlier in the same year, which was not a triple-negative breast cancer. And her core was IDC grade 3, triple-negative. The options here are for her to have upfront surgery or neoadjuvant chemotherapy, and I don't think there would be much conflict with this patient. There are various reasons for giving her neoadjuvant systemic therapy, and one of them may be that germline testing may be considered, and I can see my medical oncology colleagues thinking about how they might change her treatment. Here's another patient in contrast, and I've put up the contrasts in red. This patient was 33 years old. She had the same 2-centimeter lesion in her breast, but was clinically node negative. She also had a triple-negative breast cancer. There was no cancer at all in her very close relatives, but in the distant family on both sides, there were some hematological malignancies, which are probably unrelated. In this patient, the decision is a bit more nuanced, isn't it? Because whatever we do for this woman, whether we do upfront surgery or neoadjuvant therapy, what we would be considering would be to give her breast conservation, and yes, she will need chemotherapy, and yes, following breast conservation, she's going to need radiotherapy. There's an argument for upfront surgery, because after all, she has stage 1 disease, but also there's an argument for giving her neoadjuvant chemotherapy as well. What this would do from a surgeon's point of view is it gives a window for germline testing, because to get the results often takes 4 weeks or even a little longer, and the surgical options may be changed based on the results of her mutation testing. So here are the questions to us as surgeons. The first one is, if she is BRCA mutated, can breast conserving surgery be recommended? And the second consideration is whether additional surgery is required either to her contralateral breast or her ovaries. Let's have a look at the evidence. Now, from this meta-analysis, which was published a couple of years ago, you see that at 5, 10, and 15 years, there is a difference in the incidence of local recurrence between patients having breast-conserving surgery and having mastectomy. But if you look at the long-term cancer outcomes, both at 5, 10, and 15 years, there is no difference in either breast cancer-specific mortality or overall survival, whichever sort of surgery they had. This is also nicely shown in this, which is another systematic review and meta-analysis, where there is a difference in loco-regional control, but no difference in the other cancer-related outcomes. So it seems that breast-conserving therapy and mastectomy have equivalent outcomes, partly because any further breast cancers tend to be low-grade and picked up early, small tumors. So the answer is that breast-conserving surgery may be offered with equivalent survival. Now, what about additional surgery? For these two patients I showed you, there is a difference. Following the treatment of locally advanced breast cancer, we should definitely defer doing anything to the contralateral breast if she has triple-negative disease by at least 2 or 3 years. If she has ER-positive disease, it also depends on the prognosis and how you think she's going to do from the point of view of early recurrence. Oophorectomy, on the other hand, may be advisable depending on her age, but because of the risk of ovarian cancer and not because of breast cancer. However, with early breast cancer, there might be a different approach. Now, what are the different things we could do? Let's look again at evidence. What about contralateral risk-reducing mastectomy? Well, it reduces the incidence of cancer in the contralateral breast, but there is very limited evidence for any improvement in survival, even considering that survival data may be skewed because you're offering it to patients who are younger, healthier, and with less comorbidities. In spite of this, there is really no evidence, no clear evidence for improved survival. What about oophorectomy? Well, it certainly reduces the risk of ovarian cancer. This is a review from a few years ago, but it doesn't seem to change the risk of contralateral breast cancer. There is, because it reduces ovarian cancer, there is a reduction in all-cause mortality, which is most pronounced in patients with a BRCA1 mutation. So the answer to the second question is that additional surgery may be offered, but selectively and really focused on patients who present with early and good prognosis disease. So let's have a look at that patient. If we did upfront surgery for her, we would be considering conservation, chemotherapy, and radiotherapy in that order. But if she has neoadjuvant therapy, we could still stick with breast conservation if she doesn't want to have testing or if she tests negative. Even if she has a mutation identified, it is okay for her to have breast conservation. But there is another route for her. If she has a mutation, she could consider having a mastectomy or even a bilateral mastectomy with or without reconstruction at her choice. It also leads to a possible alteration in her systemic regime, and a little benefit is that radiotherapy might be avoided for this patient if she had a mastectomy. Let's have a look at another patient, and here again, 2-centimeter tumor in the breast, node negative, but this time we have a patient with ER and PR positive, HER2 negative disease, luminal B. We would be cautious about offering neoadjuvant therapy to this patient, but look at her family history. Her mother and her maternal grandmother, both deceased now, both had ovarian cancer. But with this disease, would we really be thinking about delaying her surgery until she had germline testing? No, I don't think we would. This is the sort of patient where we would offer upfront surgery and we would offer her breast conservation. Because also remember that her systemic therapy would remain unaltered, whatever the result of her testing. We could test her while she was having adjuvant therapy, and she might test negative, or there might be a mutation identified. If she did have a mutation, she could still remain with breast conservation, but with some additional surveillance over the next few years, or else there could be a different route altogether. There could be further surgical considerations, one of which would be a risk-reducing salpingo-oophorectomy, and the other for the breast. She might be able to avoid radiotherapy, as with the last patient, so she could have unilateral breast surgery, bilateral breast surgery, or with or without reconstruction by testing her during her adjuvant chemotherapy. Look at this patient who we treated in 2016. She came to us with a 36-year-old with a right breast cancer, 2.5 we operated on her, but look at that family history outlined in red there. Her mother had ovarian cancer at the age of 52, 3 maternal aunts had breast cancer in their 40s. This is her histopathology result, 2.4 centimeter grade 3 lesion, sentinel lymph nodes were negative, ER and PR strong positive, HER2 negative, the KI and a high KI. She declined germline testing. Her brother is a doctor, and between them, she came from Bangladesh, her brother is a doctor, between them they decided that they did not want to go down this route. Let's see what happened in 2018, 2 years later. Her sister, who was then aged about 40, came to us with a new breast cancer, and suddenly the whole situation changed within the family. Both sisters had germline testing. For one of them, the one I'm presenting to you, it was about 2 years after her treatment. She ended up with completion mastectomy, contralateral mastectomy, and risk-reducing salpingo-oophorectomy, all at the same sitting, more or less at the same time that her sister decided to have bilateral mastectomy. The decision changed entirely once they actually knew that they carried a mutation. Yet another patient, and I want to show you this is another interesting one. This is a patient who we treated recently. She presented to us at 52 years with a triple-negative breast cancer, having had her first triple-negative breast cancer in the contralateral breast at 38 years, and having had a breast-conserving surgery in TMH in Mumbai at that time. 2 triple negatives, so she's got bilateral disease and she's got triple negative disease, and we tested her when she came with recurrence with this isolated contralateral breast cancer, which was a small one, no metastatic disease, but her staging did show an additional small ovarian cancer. I want to show you her family history because it's important. If you look at her immediate family, it looks to be irrelevant, but if you look a bit further, with all these intervening relatives being male, there were multiple breast and intra-abdominal cancers in her family. So it's important to take a very clear and extended family history in this kind of a patient. Finally, I want to show you a woman who does not have breast cancer. She's with us at the moment. Earlier this year, 2 of her sisters were diagnosed with breast cancer. Again, this is a patient from Bangladesh. Her older sister had breast cancer with negative for a mutation, and her 39-year-old younger sister also had breast cancer and was found to have a BRCA1 mutation. There are a few other cancers in her paternal family. So it's important to remember that these things all come together. Just because she had one sister who had perhaps a sporadic type of breast cancer does not mean that the family doesn't carry a germline mutation. She has no personal history of breast cancer. She may or may not get it in the future because it's important to remember penetrance, meaning that not every person with a mutation is actually going to get cancer. So the surgical question for a mutation carrier is when to consider prophylactic surgery and what surgery that should be. More evidence. So let's have a look at oophorectomy first. So oophorectomy, particularly in younger people, and especially in BRCA1, I'm more or less on the last couple of slides. BRCA1, there are some improvements in various cancer-related outcomes. However, risk-reducing mastectomy reduces the incidence of breast cancer, but much like doing mastectomy in people with primary breast cancer, there is no survival advantage. However, it does reduce anxiety a lot, and it reduces patients very often want to go ahead with it because of the extreme anxiety that they have related to breast cancer. So this unaffected patient, it's important to remember to advise lifestyle modification to reduce cancer risk. She could go down one of two routes depending on what she wants. She could have surveillance both for her breasts and with less evidence possibly for her ovaries. If she wants to have an intervention, it's the other way around. The first intervention that she should have if she wants to go that way should be for her ovaries. She could have an oophorectomy, and depending on what kind of a gene mutation she had, there might be a different age for that. There is also some upcoming evidence that she could have a salpingectomy on its own, or have it alone now, followed by oophorectomy at a later date. If she wants breast intervention, then she can have breast prophylaxis, which could be a bilateral mastectomy done at any age, which could be either conventional or nipple sparing with reconstruction. So finally, in conclusion, gene mutation results do affect surgical decisions, both at the time that patients present with cancer, at the time of recurrence, and in both primary and secondary prevention. It's important to bring these into our treatment algorithms so that we can offer the best options to all our patients. Thank you.
Thank you. Any question from the audience?
I was very intrigued by one of the slides where you showed that breast conservation surgery done in these mutated patients, as compared to mastectomy at 5, 10 and 15 years, the local recurrence was obviously significantly lower in the mastectomy group without having any influence on the overall survival.
Yeah, that is true.
So that's probably the only way you can explain it, is because they had malignancies elsewhere in the ovaries probably. So is there a subset of those patients who also underwent a risk reduction salpingo-oophorectomy, and was the outcome equally bad in those patients?
I showed that, there is, when we talked about salpingo-oophorectomy, there is some improvement in overall cancer outcomes. But, breast conserving surgery is safe. Breast conserving therapy, I should put it, which is breast conserving surgery with appropriate radiotherapy. It is safe if a patient wants to have it, and then she can have surveillance for the other breast. A new cancer in the other breast is usually, for both breasts, new cancers are usually picked up early.
I think it would depend on how you define safe. Having a local recurrence is not really what I would call a safe outcome, even though it may not translate into a worse survival advantage. Local recurrence is not something which one would desire.
Yes, well, it needs to be discussed with patients, and it depends which way they want to go.
Okay, thank you, Rosina. I would now request Dr. Rima Pathak. She's consultant radiation oncologist at Tata Memorial Center, Mumbai. Rima is well known to the radiation oncologist, and she will speak on nodal radiation in ultra hypofractionated radiotherapy.
Thank you, sir, for your kind words. And the initial few slides I'm going to zip past because my colleagues, both during debate as well as during the panel, introduced you to the ultra-hypofractionated radiation therapy. So I do not have any conflicts. So before we start this particular topic, I would just like to establish a few things. That there's no evidence to suggest that nodal disease requires a different radiation fractionation as compared to the treatment for the primary disease, and that skin over the neck is the same as skin over the breast, and they should not be reacting any different way. Also, I would like to say that conventionally and moderately hypofractionated regimen use the same doses for both regional nodal irradiation as well as the breast and the chest wall. So long as we've established that, we'll move forward. Now again, this is the schema for UK fast forward study. The UK fast study did not have any nodal irradiation, and we will not go into the details. There were several eligibility and endpoints defined in the study. I will again not go into the details, but just say that operable breast cancers with any type of surgery, any grade, but not requiring regional nodal irradiation were used in the fast forward study. However, they did have a nodal sub-study which was opened subsequently. They did look at several endpoints which are listed over there. Now I will delve on this particular slide a bit more stringently, is because they had uniform and stringent radiation planning criteria. They did have uniformity in their quality assurance, and they had to repeat credentialing for each and every site, both for QA and QC for imaging, planning, as well as execution purposes. You are familiar with these dose constraints that are put up, and they did have adherence, a very strict adherence to these dose constraints as well. The study population was 4,000 patients with these particular population characteristics, more T1 and T2, less HER2, less TNBCs, fewer patients with LVSI, only few patients having neoadjuvant and adjuvant chemotherapy, and smaller proportion having tumor bed boost. The acute skin toxicity sub-study showed, and this is important because we are talking about toxicity, and this will also, we are going to translate these results to the regional nodal skin also. So here they showed that acute toxicities between the 26 gray arm and the 40 gray arms were fairly similar. And as you can see over here, the toxicity with the fast forward study peaked at 2 weeks and not at RT conclusion, and this is something which is important as practical consideration. They looked at primary and secondary endpoints, and these are recurrence rates. Again, we go back to the rider that we had established before, that the recurrence rate between primary and nodes are going to be similar because the dose-response relationship is similar. And here they found that the 5 fraction, either it was 26 or 27 gray in 5 fraction, was similar to the 40 gray arm. And therefore, both of these 5 fraction arms were non-inferior. They looked at subgroups to see if there were any early results showing that some particular subgroup or high-risk subgroups did worse. Here they saw that both of these fractionation regimen were similar in their outcomes for these patients. Looking at PROMs, here again we established that the 26 gray arm was non-inferior to 40 gray arm across all different types of PROM endpoints except induration outside tumor bed. Physician assessments, again, will not go into the detail, but showed exceptional compliance to quality of life and PROMs at 5 years. And we saw that the NTs and PROMs were similar between 26 gray and 40 gray. Cosmetic outcomes, again, were similar between 26 and 40 gray, and therefore we would establish that across several endpoints that we've defined, 40 gray arm was equivalent to the 26 gray arm. In terms of late toxicity, and this is where everyone would want to ponder, at 5-year endpoint, you would not expect too many late toxicities to have come, but it at least gives you an early start to see if there were any early indications. And here they saw that the rates of late toxicities were also lower. So the conclusion was that both 5 fraction regimen are effective. 26 gray is similar in safety profile as the 40 gray arm. Acute toxicities are low, and possibly late toxicities would remain low. Now what we would assume now is that the regional disease control will be similar for both 5 fraction regimen for regional nodes as well. Skin and subcutaneous tissue over the neck and chest wall will have similar outcomes with regional nodal irradiation. However, what remains to be seen is pharyngeal, esophageal, tracheal, and brachial plexus toxicities. They need to be evaluated further. We would include these regional nodal target volumes whenever we do regional nodal irradiation. Now, historically, we've seen several problems with hypofractionation, and which is why hypofractionation was not encouraged, because it led to several toxicities as listed over here. Here you can see that 60 gray in 5 fraction was used, similarly 50 gray in 16 fraction, and all of these have shown to have significant high brachial plexopathy. Now, we also had, many of us would be aware of the UK RAGE group. This is the radiotherapy action group exposure. This particular is a set of women who came together who had undergone radiation therapy for their breast cancer and developed serious late toxicities. Here you can see that the brachial plexopathy developed in, the median time to development of brachial plexopathy was 2 years. And we also see that not just brachial plexopathy, several serious side effects were seen in a whole lot of patients who had received radiotherapy previously. What was interesting to see is that most of these toxicities occurred because of change in position of the patient. So previously, now most of the modern radiotherapy ensures that the patient position does not change between the tangents and the regional nodes, whereas this was not the case previously. And it was encouraging to see that in this RAGE exposure report, they found that hypofractionation was not equivalent to higher toxicity. So there was some satisfaction when we saw that. It was important, again, establishing the same thing wherever there was major movement. Most patients developed plexopathy, whereas there was no movement, these rates were lower. Now, why is it important, and how does this plexopathy develop? There are several. I will again not go into detail. You have microvascular injury, radiation-induced fibrosis, direct neurological injury. all contributing towards plexopathy. And what does plexopathy do? It gives us chronic handicap. It's usually progressive and frightening, irreversible, has sensory disturbance, gives pain, dysesthesia, paresthesia, and mimics carpal tunnel syndrome, so several times confused with something else. It also can develop motor weakness and complete paralysis, and this is where it hits us hard whenever these patients keep coming for our follow-up. And treatments are, again, very ineffective. There's a long list of treatments, again, put over here, but none of these treatments are going to reverse the plexopathy if discovered late. There are several factors that contribute towards development of brachial plexopathy. Again, these are, again, machine-related factors, and then you have patient-related factors. Some could be surgical trauma, some could be also the age and comorbidities of the patient. But what is important to see is that a whole lot of things can be modified. A whole lot of things are still in our control. What does the contemporary data show? So the previous data was from 1960s and 70s, and what is our current data? Now, this is extrapolation from treatment of superior sulcus tumors, and extrapolation of treatment of central midline structures with SPRT type doses, because we are talking about using dose fractionation upwards of 5 gray per fraction. So here, the initial results of RTOG 0813 initially showed that there were bizarre side effects like bronchial stenosis, fatal hemoptysis, and central fistula after treatment of central structures in lung cancer. And similar study results from the phase 2 Nordic HYLA study were quite scary, showing that nearly 19% had grade 4 or grade 5 toxicity after treatment in 60 grain, after treatment of 60 grain 8 fractions. So most of these patients died of fatal lung hemorrhage, and what they saw was that the PTV overlapped with the bronchus in these patients. These are important guidelines that allow us to understand what is the dose limiting toxicity and what are the doses that are safe in these kind of organs at risk. So UHFRT and regional nodal irradiation for breast cancers, can we draw parallels for these patients? So there was a nodal sub-study which was again used with the fast forward, and here you can see that in this nodal sub-study, previously, so the endpoints were patient-reported arm and hand swelling at 5 years. There were several secondary endpoints listed. And this was looked at very carefully by using the LQ modeling. As you can see over here, and I might just take a second, on the right is the 107% isodose. So this is the BED and EQD2 of all your hotspots. You've all heard about double trouble, and this you can see it happen using the LQ model over here as well. And as you can see, the threshold is at 26 grain 5 fraction. The moment you turn over to 27 gray, it suddenly becomes too hot to handle. The advantage 28 grain 5 fraction has is that it has a cooling period in between where the lethal and potentially lethal damage can get repaired, and which is why the toxicities with this toxic regimen are much lower. They used a whole lot of credentialing, whole lot of quality assurance, and which is why they could float this particular study. As you can see over here, the stringent criteria laid out for them. The randomization criteria changed in between because they found that the 27 gray arm was fairly toxic as compared to the 26 gray arm, and which is why in the nodal sub-study, midway through, they dropped the 27 gray arm altogether and revised it to just comparison between 26 and 40 gray arm. So what are the nodal sub-study results in terms of lymphedema? You can see that the lymphedema rates were similar. As compared to the 26 gray arm, there was no difference. In terms of the different patient-reported endpoints such as swollen arm, arm and shoulder pain, and all of these particular types of endpoints, you saw that the 26 gray arm was very similar to the 40 gray and 15 fraction arm. And there was no indication to suggest that the arm and shoulder morbidities were any different at 3-year time point. We also heard a whole lot about the interim analysis of the HYPORT study, and this is important because this is Indian population. So in this particular study, they showed that the overwhelming majority achieved strict dose constraints that were laid out by the study. You can see over here, this is very much representative of our normal Indian population of breast cancer. And the HYPORT study results showed that there was no signal to indicate excess toxicity within the test arm. However, odynophagia was not reported in this particular study. We have a whole lot of experience due to the pandemic where we started treating patients in 5 fractions, and we saw that Across the type of patients that we usually see in our clinics, toxicities were fewer. As you can see over here, even grade 2 toxicity was less, 6 to 7% in terms of skin toxicity, and in terms of odynophagia, that means difficulty in swallowing, you would have 6 to 15% of patients, which peaked at around 2 weeks. None of these patients required hospitalization, not for dermatitis nor for dysphagia. And that is why it is important to understand the safety in Indian patient profile as well. So here I would say that majority of our patients we were treating using simple 3D CRT or field-in-field IMRT. So no special techniques were used. You do not need special equipment. This is possible if you have good quality assurance and good planning team backup. We produced mild toxicities. We have till date not seen a single patient of brachial plexopathy or complaint of having even grade 1 side effects in terms of neurological side effects. So if we do a fact check, is it feasible? Yes, it is. Disease control-wise, similar. Acute and late toxicities are similar. PROMS-wise, it's similar. It is very well tolerated, even in Indian population. Is it generalizable? So this is a point which each of us will have to introspect and think whether your setup is capable of treating patients with ultra-hypofractionation. If your setup is doing SBRTs routinely, I guess then that's not a big deal for you. So currently, who can be treated with ultra-hypofractionation, especially with regional nodal irradiation? So because we have published and unpublished data of safety among even Indian population with low toxicities, I would think that at least elderly, where you have a choice to be made whether a patient will receive radiation versus not receive radiation, it is safe to say that at least 5 fractions of treatment will be better than not giving radiation whatsoever. So patients who have non-compliance factors, functional limitation, who can't travel the distance, have several comorbidities limiting them to come to your therapy center for 3 consecutive weeks, you could choose these patients for ultra-hypofractionation. We have real-world data from our setup, and we are trying to collate data from other centers who have started using ultra-hypofractionation during the pandemic. And this particular data set will be very valuable to see whether this is generalizable even in our setup. Who can treat? Like I said, centers who have strict quality assurance of machine contouring, planning, and execution, and those that are able to use monoisocentric technique can go ahead and treat these patients. I would like to acknowledge a whole lot of people who have helped us adopt this particular, and the whole DMG and the department has helped us take it through. Thank you so much.
Thank you. Any question from the audience?
You said brachial plexopathy is a serious concern. Yes, it was a serious concern previously when he used to irradiate the axilla, but now it has gone down. Plexopathy. So is it related to the type of study, either a fast or you complete it in 5 fractions? Does it?
So again, if you see several times when you increase the dose per fraction, you may end up seeing bizarre toxicities that you had not imagined before with conventional fractionation, and that is what I showed in the RAGE group report that was presented. So several times you would require some long-term data before you can adopt. However, what I can safely say today is because of the LQ modeling, and even if we consider the time factor, the grade 3 and 4 toxicities are very less likely because of the total dose reduction that we have in this particular regimen. Like 26 grain 5 fraction is not supposed to technically give you those kind of biological side effects that we are talking about. However, in future, these patients tend to live longer. 15 years from now, 20 years from now, will they have strictures or not? I don't know. And only time can tell whether the hypofractionation affects these organs in certain adverse manner.
Even if we do not irradiate the axilla?
No. If we don't irradiate the axilla, also you will have the brachial plexus in your supraclavicular portal. So while we are not treating the axilla, supraclav, and I haven't shown you the report over here, but majority of the patients who did have plexopathy had the supraclav irradiation and not the axillary irradiation. So it's the supraclavicular part of your brachial plexus which is more susceptible because of the superficial depth. So no, we don't contour the trachea and the bronchus, but what we try and do is angle our anterior fields in such a manner that majority of the volume is outside the treatment portal.
Okay. And in your ultra hypofractionation, are you radiating the nodes?
Yes, we are.
Supraclav?
Yes, we are. So
Okay.
right now, like I even mentioned during the panel, is that the practice that I have shown is during the pandemic where we were treating all patients using hypofractionation or ultra hypofractionation.
Right.
Routinely now, only node negative patients are being offered the 5 fraction treatment, or elderly patients where we don't have any other option.
Okay. So there you're giving ultra hypofractionation to
and
the nodes.
like I had shown over here, the data here I have shown is 70% of them required supraclavicular radiation and 10% required IMC radiation as well.
Okay. Thank you.
Thanks, Rima, for the nice talk. So for
Thank-
that supraclavicular radiation, what is the technique you are using? Is it a direct field or an IMRT?
It's a direct field.
Direct field.
We are not using IMRT for anything except if it's a deep tumor bed.
So what is your take on like contouring the brachial plexus and doing an IMRT for the supraclav if you are using ultra hyperfraction?
So again, if you see, we use the same plan as we would have done for 40 gray in 15 fractions. Our plans are very interchangeable. And the dose to the brachial plexus, the max dose to the brachial plexus comes down to around 30 gray. So 30 gray, sorry, not 30 gray, 20 gray. So 20 gray in 5 fraction is known to be safe since time immemorial because it's our palliative fractionation. And we don't, that is why contour the brachial plexus for all of them.
Okay, that's a good information.
Yeah.
Thanks.
Thank you, Dr. Rima, and we are concluding the session now.